one of the things it does. You can sit there and hammer it in and do the same thing, but from a synergy point of view, that is what we use. So that's what I use. So this picture shows the basic vectors and activities that go into that posterior reorganization of the glenohumeral relationship and scapular-thoracic relationship. Okay? So, what are the signs of anteriority? The signs of anteriority are that the humeral head in resting is forward, more than a third forward in relationship to the square box of the acromioclavicular joint. The other is that it moves. It can be centered, but during dynamic motion, it moves forward at some stage during the arc of movement. And with it are usually accompanied trigger points around the joints, and limitation of motion often is present, except for people who are quite lax in their shoulders. You may not notice the limitation of motion so easily, but it is there with disturbance of the alignment. So those are really one of the things you can see, both in terms of the position. You remember in prone lying, you may see the humeral head fall down. In the activation of the 3-month position, you may see that there's inadequate activity of the posterior deltoid. And let me see if I have that position. It's probably further along. There you go again. Yes. And often we see that type of position of the shoulder inside oblique. Yes. So you can see that it is improved by activating better the and releasing the tightness at the posterior of the posterior aspect of the glenohumeral joint and the anterior aspect of the chest. Because what happens is that this happens and then this goes back and you get that zigzag function. So we know that the scapula must be stabilized, and we do that through many times the 3-month position, the side position, and we also do it through upright positions, which I showed in the last course, where we are using modified 3-month position on the head against the wall, because it is important for many of your clients to feel what stabilization is like in upright function, so that it does not, because sometimes the position on prone does not translate to the sensation in standing. It is good in prone to assess what the difficulties are in achieving that position. It is good in prone to assess the muscle pattern around it, but when it comes to exercise and actually getting into synergies, you have to upright that whole position as quickly as possible so the patient can feel the same synergy and sensation in verticalized standing and work with that in the vertical plane. Because that is where the rubber meets the road. Most people are not lying down doing work. So we look at tightness of the range of motion, and you can often see this. And this is often what you see with tightness of the glenohumeral adyductus, that the scapula is pulled out abnormally by abduction or flexion of the arm, and there is flexion at the elbow as compensation, and many times you can also palpate muscles along the outside and along the anterior that contribute to this abnormal position of the arm. These are all going to have to be released or treated so that the shoulder can sit better. So the glenohumeral adductors often give a concavity, again, in this area, and it is usually tender and unpleasant to treat, but we will treat it anyway. It is also important to treat the fascia of the pectoralis area. So I'm using here, you can see the joy with which my patient experiences that upside down. He is in agony, but it has to be done. And that is using the shelf liner to pull the fascia caudally, because if not, the fascia will keep the rib cage superior. This all has to go down if you are to bring this rib cage down without excessive abdominal activity. So when you find that the person is having difficulty having the canister, you must make sure that all this platysma and the pectoral fascia is free to allow the ribs to descend, or they will be fighting the abdominal wall and you will cause pain in the thoracic region from this unnecessary tug of war that's going on.
Robert,
so, yes.
When you do that release, will you time respiration,
yes.
a respiration
yes.
pattern with that?
Yes, and you can time it with muscle activation. This can be done in 6-month position so that his legs are on the ball, he can rest, and then he breathes in, and when he breathes out, he lifts his leg and I pull the fascia down so that the abdominal wall will work with the release of the fascia and reset those receptors and the sensation of release and activation. So here we're doing some manual work, and here is the patient working on actively rotating the thorax away from the scapula on the table so that it is not just a stretch. The patient turns the scapula, turns the thorax with the obliques and the weight of the legs away from the scapula and helps to stretch that themselves. Yes. And it is an important concept to be able to fix the scapula and turn the thorax on the scapula as opposed to moving the scapula on thorax. Yes? Because when it comes to repositioning rib rings, you must be able to have punctum fixum and punctum mobile of the ribs against the scapulothoracic plate. This is utilizing again. I pull the pec up, not very nice. He breathes out, and again I lift the pecs, pec minor and major, and he stretches them himself by exhalation against my finger. Another pleasantly unpleasant treatment. You can do it gently, of course, but it is not initially very nice. But it works. Because you must remember that this pec minor takes the first 4 ribs. So they go nowhere if pec minor doesn't say yay. They will not go anywhere. They will move as a block with the pec minor. This is a good position for releasing the muscles and also doing soft tissue work on the muscles, the periscapular and periglenohumeral musculature even biceps is relaxed here. You can get into the long head of the biceps because the deltoid is relaxed and everything is soft. So it is a good position for that. That just shows you when I'm doing, remember the first part we did the stretches, so you can use that position to activate muscles like the pec, etc. So this we will come to. And retraining the scapula, we can start in earlier than 3-month position, because sometimes the 3-month position is not, the patient cannot find the scapular activity. And so every time you get to the 3-month position, or the, what we call 3-month is really is not, but when we get there, the patient is fighting to find it, and it is just not working for them. Sometimes the adductors are too tight. So on your way to releasing it, you're working on the scapula. You cannot bring them up because it decentrates the scapula already. And so you must work in a range that allows the scapula to meet the thorax, even with the tight adductor contractures. So this is my patient doing just that. And this again is my patient with facilitating the support function through the arm and thorax, as you know from DNS. And then we go into very important 4.5 months position for the diagonal chains. This is the beginning of a strong activation of the diagonal chains in prone function, and has a very important use all the way into the contralateral knee. Okay, so what I want to do then